in this video we shall be discussing regarding the Helicobacter pylori infection. So this has been gaining importance in your recent days and hence becomes a very important topic also with respect to your exam. So what are your diseases associated with it? So it is associated with your peptic ulceration, then it is associated with your gastric carcinoma, it is associated with your chronic gastritis, and it is also associated with your moltoma, right? And then duodenal ulceration is associated with around 90% of H. pylori infection, whereas your gastric ulcer is associated with around 70% cases of H. pylori infection. Now a few detailed explanation regarding your pathogenesis, as previously there have been questions asked from the pathogenesis of your H. pylori infection. So the protein in the Helicobacter pylori organisms is mainly composed of your cytoplasmic urease. Now this converts the periplasmic urea into CO2 and ammonia. Right. Now this ammonia is responsible for buffering the surrounding acid, which allows the bacteria to survive in the minimal luminal environment until it can burrow deeply into the mucus with the help of its flagella. So H. pylori organisms are flagellated organisms, right? So now when it burrows deeply into the mucosa, it is an attachment, right? It does not invade. So this attachment to the epithelium triggers the host immune responsible, as a result of which various factors are secreted, like your neutrophilic activating protein A, heat shock protein 16, salicylic acid binding adhesin, and this toxin, which are CAG-A and BAC-A. Now this causes the inflammatory reaction, which causes the recruitment of your neutrophils and the recruitment of lymphocytes, plasma cell, and the macrophages, as a result of which your chronic gastric inflammation occurs, which is characterized by increased apoptosis, mucosal cell DNA damage, chromosomal instability, presence of reactive oxygen species, and enhanced mucosal expression. So as a result of this chronic gastric inflammation, there is a weakening of the mucosal defense. Now because of this weakening of the mucosal defense, what happens is that your H. pylori avoids the recognition and destruction by the mucosal immune system and is responsible for its various effects. Now in case of your duodenal ulcer, what happens is that because of the acquisition of the H. pylori, there is chronic H. pylori infection in the stomach, which causes your somatostatin and your gastrin dysregulation, as a result of which it causes your increased acid secretion. Now this increased acid secretion as well as the chronic H. pylori infection in the stomach is responsible for your gastric metaplasia in duodenum. Now this gastric metaplasia in duodenum is responsible for your H. pylori colonization in duodenum, as a result of which there is decrease in the bicarbonate secretion and it causes inflammation, as a result of which your duodenum ulceration happens. Now other few important points regarding your H. pylori include your for diagnosis your urea breath test. So please remember this urea breath test with respect to your H. pylori infection. Then how do you manage such cases? So we have an algorithm for your management of the suspected duodenal ulceration. So in this algorithm we check if the age is more than 50 years or if there is any presence of alarm symptom. So what are your alarm symptoms that could be present? It would be your bleeding, then it could be your weight loss, features suggestive of malignancy, and then we have your persistent vomiting. Now if this alarm symptoms are not present, then what you do is a urea breath test or a stool antigen assay or a stool antigen assay. Now, if this is positive, then what we do is we treat for the H. pylori infection. Treat for H. pylori infection. Now, if the alarm symptoms are present, then we go for an endoscopy with biopsy, right, for the H. pylori urease activity as well as for the histology. For H. pylori and histology, right. Now, if this is positive, then what we do is treat for H. pylori infection, right. Now, if this is we treat for the H. pylori infection and then we again confirm for your H. pylori eradication. So, if it is not eradicated, then what do we do? So, if it is not eradicated, then we repeat endoscopy with biopsy for culture and antimicrobial sensitivity. Then we repeat endoscopy for biopsy with culture and microbial sensitivity, right. So, these are your some important points with respect to your H. pylori management, which is simplified in this flow chart. Now, regarding your drugs used for your H. pylori infection, so we look for the clarithromycin resistance, right. If it is less than 15%, then what we do is we give a standard triple therapy. Now, for how long it is given? It is given for 14 days. Then the next question that is asked to you, what are your components of your triple therapy? So, the triple therapy includes your amoxicillin, then it includes your clarithromycin, and then it includes your PPI in your double dose. So, amoxicillin is present in 1000 milligram and your clarithromycin is present is 500 milligram. Now, if this standard therapy fails, right, or if the clarithromycin resistance is more than 15%, then in such instances we go for your bismuth based quadruple therapy, right. So, what are your drugs in your bismuth based quadruple therapy? It includes your PPI and your double dose, right. Then it includes your tetracycline in 120 milligram QID, then it includes bismuth, which is again 120 milligram QID. I think no, this tetracycline is not given in 120 milligram, it is rather the dose is your 500 milligram, and then we have your metronidazole, which is 500 mg TDS, right. So, we have this bismuth based quadruple therapy, which I would want you all to remember the drug's name, which has your tetracycline 500 QID, bismuth QID 120 and metronidazole 500 mg TDS, and this is also given for a duration of 14 days, right. So, this is all about your H. pylori infection.